costs in other ways. There's costs in terms of lives lost. There's costs in terms of what is HIV doing to the economy of South Africa. What is HIV doing to the individual? And that's what we're going to be talking about in this lecture. It's based on several research studies and the current epidemiological data that we have in South Africa from the WHO, from the Department of Health, and from the Actuarial Society of South Africa, and from the UNICEF. Those are where all these statistics come from. Some people say, oh, you're an American, you always blow statistics out of proportion. All of these statistics come from South Africa. So as an overview, what I want to do is focus on the prevalence of HIV, which means how many people have HIV right now, the impact that that's having on the population, the impact that that's having on health measures. We're going to look at the different health measures and how HIV has changed that in South Africa. We're going to look at the potential impact that HIV has had on the economy. Well, that's hard to say. How can I say, what has HIV done to the economy? What has HIV done to the economy of South Africa? It's hard to measure that sort of thing. So what I'm going to do is show you some statistics from Swaziland, a small little country that actually borders KwaZulu Natal. And you'll see from some of their statistics on their economy about what's been happening over the last about 10 to 15 years, you'll see what's probably impacting also South Africa, but it's a harder statistic to measure. And then we're going to last talk about how are we doing in terms of treatment currently in South Africa. This was the prevalence, or what the prevalence of HIV looked like in 2006. You can see here that the majority of those HIV infected are in the young, in their prime of their lives. Mostly, and you can see females affected slightly more than males, and it's mostly between the ages of 20 and 50. That's the majority of the people infected by HIV. This is when you should be most productive. You've finished school, you've passed your matric, you've gone on to maybe higher education, and are now working. But yet now you're HIV infected, and that will impact your production. Well, where does South Africa rank in terms of prevalence in terms of the entire world? Well, it actually ranks number 5 in the whole world. As you can see above us, every other country is also in Southern Africa, and everyone actually borders with South Africa. And you say, but I thought South Africa was really bad. How come it's not number 1? Well, because all these other countries are much smaller than South Africa. And when you look at prevalence, it's percentage of people who have HIV right now. So these, well, Zimbabwe is a little bit larger, but the 3 countries above, the largest in terms of population is Lesotho at only about 2 million people. So you can see that South Africa, in terms of percentage of the entire population, is number 5. But if you look at it a different way, it might actually be even worse when you look at where the infections are occurring. This is the antenatal clinic prevalence rate beginning in 1990. You can see the trend there is straight up. As patients are becoming infected more and more and more. And this was ended in 2005, and it started to level off, but it's even higher than that now. It's more at about 35-36% nationally. But it started to level off. It's not climbing as high as it was here in the late 90s and early 2000s. But you can see the trend. Those females who are in the prime of their lives are becoming infected with HIV. If you look at it by age, you can see the most infected is in the yellow triangles, 25 to 29, followed by 30 to 34. Again, in the prime of their lives, the number of females infected. If you look at province, which province is most infected, yellow is KwaZulu Natal. And you can see that over the past 5 years, KwaZulu Natal has hovered right about at 40% prevalence rate. Which means if a pregnant woman comes into your clinic In KwaZulu-Natal, 4 out of every 10 women in that queue is HIV positive. 4 out of every 10 women, 40% in KwaZulu-Natal, if they're pregnant, are HIV positive. This is a different graph with different colors, but as you can see, KwaZulu-Natal again is the top and has the most. This is the projected, this is taken from a computer model that is projected into the future. Of course, we can't tell the future, but these computer models can try to guess at what may happen in the future. And I'll show you several of these, and these come from the Actuarial Society of South Africa. And you can see what has actually happened. For about the past 4 or 5 years, we have hovered right at about 40%, and that's what is projected to continue for KwaZulu-Natal. What about incidence by age? Now, incidence is something that's different from prevalence. Prevalence is how many people have HIV right now. Incidence is the number of new infections. So these are the number of new infections that are occurring each year. So again, you look at your age groups. The most infected are females 15 to 24. That's the pink line up there. Is females 15 to 24. And you can see they all peaked right at about the late 90s. The late 1990s, most of the new infections, as we knew about HIV, as we knew about preventative measures, they started to come down. But what has happened in females 15 to 24? It has not stopped. And the number of new infections is continuing and is projected by computer models to continue at the same rate. So I want you to look at where we are now. So this is, we're actually about over here now in 2010. Females 15 to 24. This is the number of new infections per year, which means last year about 160,000 females from that age were infected. Which means this year about 160,000 females in that age will be infected. Which means the next year, you see what's happening? There's a target age group, these females that we're not reaching. And again, these have not continued to drop dramatically. They're holding, most of them are holding pretty steady, and they're not declining. The number of new infections, those that we would have prevented, looks like we've done so here. But now, whatever we're doing now isn't really seemingly to affect the computer model. What about in terms of people living with AIDS? Well, South Africa is number one, and number one by far. South Africa has the most people infected with AIDS in the entire world. At 5.7, some estimates say 5.8 million people right now are infected with HIV in South Africa. You can see India, Nigeria, Zimbabwe, Tanzania follow suit. To put that into perspective, you knew that the number one in prevalence was Swaziland, and then coming down. And they included Botswana, included Swaziland as well. So those 3 countries were also in the top 5 in terms of prevalence. But in terms of actual number of people infected with AIDS, South Africa has more than the entire populations of these countries combined that are HIV positive. That would be as if every single person living in Botswana, every single person living in Lesotho, every single person living in Swaziland, all together, all HIV positive, still does not equal how many people are HIV positive in South Africa. So what is that going to do to South Africa? Well, HIV is different than most other infections. As you get a rising prevalence, and now the prevalence is a bit stable, not really rising, but it was rising in the late 90s, early 2000s. As more and more people are getting infected, people are living longer with HIV, you get more people living with AIDS. As you get more people living with AIDS, the impact wave sort of comes later on. Now, why is that? Because if you get infected with HIV today, the impact is much later. 5, 7, 10 years later before you actually get sick. So because HIV is a slow infection, you get infected and then it affects you not today, not tomorrow, but 5 years, 7 years, 10 years down the road. That's when we're going to feel the impact of the infections of the early 90s. When are we going to feel them? Well, 7 to 10 years later. When is 7 to 10 years later? It's now. And that's why HIV is different from things seen before. If you have malaria, you get sick now. If you had smallpox, if you have polio, if you have measles, you get sick now. HIV, you get infected now, but you get sick much, much later. And all that time in between, when you might be feeling fine, you can be passing on the infection. So what is the effect of ARVs going to have on this? Well, ARVs increase the prevalence of HIV because people will live longer. If everybody died immediately, say infections like Ebola, where 90% of the people died, those infections die out very quickly because the people die. But ARVs lengthen the time, lengthen the number of people who have HIV, so people live longer. So it looks like more and more and more and more people are getting HIV, but people are living longer, living longer, living longer, and people are getting infected at the same time. So the pool of people gets bigger and bigger and bigger and bigger. So this is an interesting but a little bit difficult concept to grasp, and I'm going to go through it a bit quickly because it's a little bit complex. But this is what's called a population pyramid. It takes the population of a country and breaks it up into segments of 4-year intervals. Now ideally, in an ideal population, it looks like a pyramid, and that's why it's called a pyramid. Lots of children are born, but then people die, of childhood illnesses, of something. They get hit by a car, they get some illness, and they die off slowly, a little bit at a time. And of course, not many people make it up to 80 and above. So the population looks like a pyramid. Well, in 2000, this is what South Africa looked like. You can see it looks pretty much like a pyramid, but a bit of a stunting down at the bottom. Already that's involving HIV, malnutrition, pneumonias. A lot of those things are killing the children less than 5 years of age. But what is projected to happen in the future for South Africa? This is a different study, different colors, but the same concept. Now the solid colors in green are what actually happened in 2006. Now the clear boxes are what's projected to happen 10 years from now. So 2016, 6 years from now. You can see that it's truncating at the bottom, and those, and it's no longer starting to look like a pyramid. It's starting to look like a column at the bottom. We're losing the people in their productive prime of life. KwaZulu Natal, even more so. You can see the big loss to people. These steps should be little tiny steps as you climb up the pyramid. But look how big some of these steps are currently in 2006 and are going to become projected to be in 2016. We're losing people in their prime of their life. This is what Gauteng looks like in 2006 and projected in 2016. So as I said, because HIV is a delayed infection, the impact wave is later. What we said was the impact, the incidence, the number of new infections occurring peaked in the late 90s, about 1997, 98. If it takes 10 years later, 7 to 10 years later, for the impact to occur, when does that occur? Right now. Right now. So what is this going to do on the pyramid in the future, 15 years from now? That's what the computer models suggest that the population pyramid will look. It doesn't even look anything like a pyramid anymore. And when about another 25 years, it looks more like a column. You've lost the balance of nature. Another thing that makes a pyramid pretty ideal is that the people in the bulk of it are the people that are working, people that are generating income, people who are making money. They can support those that are retired. and that are younger and no longer working or in school. So that's the bulk of the population is in that middle. Now it's not like that anymore. The pyramid's going to top. So now switch gears, I'm going to talk to you about HIV orphans. In 2006, in South Africa, there were over 1 million HIV orphans. Currently, in 2010, there's about 1.5 million HIV orphans. Children whose parent, at least one parent, has died because of HIV. So new orphans in 2006, there was nearly 300,000. I show a picture here of, this is Don McKenzie's children's ward when I came here in 2007. And why do I show you this picture? Because when I came here for the first time to South Africa and worked here and worked in that children's ward, there were 10 children who were HIV infected, and 10 children who were TB infected were in that ward. Only one of those children were tested for HIV. 8 of them turned out to be positive. All 10 of them were orphans. All 10. One of those children was in that hospital for 18 months. Why was she there for 18 months? Because her mother died. Because her father died. Because her aunts died. Because her uncles died. There was nobody left. So she lived in Don McKenzie Hospital for 18 months. As an 11-year-old child, can you imagine? She was not in school. Think of that times 1.5 million right now. That's what's the computers have projected, and that's what's actually happening. So you can see that the total number of orphans, which is represented by the blue line, and then the number of those orphans that are attributed to HIV and AIDS is the red line, and it's the majority. You can see the number of orphans due to non-AIDS is actually decreasing, because the number one reason for a child to be orphaned is HIV. In terms of AIDS deaths, South Africa also ranks number one, nearly 400,000. So these are pretty dreadful statistics. So what can we do about it? Well, what about treatment? What if we start people on ARVs, which luckily, starting in 2004 here in South Africa, we did. So if nobody was on HIV, that's this purple line, this is what would be happening to the number of deaths. It would continue to rise and rise and rise and reach a plateau at about 500 deaths. If we got 90% of people who needed treatment on treatment, 90%, this is what would happen to the deaths. It would only start to decline at about 300,000 and level off, and then it would continue to go up. This is what the computer model suggests. And if this default scenario is if we had 50% of people on treatment, you say, well, that's not that lofty of a goal. Only 50%. That's pretty easy. Only half the people. Right now, we're at about 30%. Right now, South Africa is about 30%. 30% of people who are in need of HIV treatment are on treatment. So, and again, you can see that the deaths would continue to steadily decrease. So what are then the costs of HIV? Well, in terms of life expectancy at birth, this is a major statistic that we look at to measure what is happening to a health system. Well, in 1990, the life expectancy in South Africa was 63. That's pretty good. That's close or near to a lot of the Western countries. But in 2007, it was 42.4. Its rank was 214. Now, there's only 222 nations in the entire world recognized by the UN. And South Africa ranks 214. It lost almost 21 years of life. And that can be attributed to HIV. There's the list of the countries below it. You can see all of them are located in Africa. Many of them are our borders. If they're not our borders, many of them have been in civil war. This is that same statistic shown to you in a graph. In the early 90s, life expectancy was about 63. Continued to drop down here. This is what the computer model suggests. With treatment of 90%, treatment of 50%, and then nobody on treatment. So at 90%, you can see the life expectancy starts to go up, but it doesn't even go back up to 55. You still see we've lost still about 10 years. And at 50%, again, we still drop all the way and level off at about 50, so we're still 13 years behind. Even if we did better at that 50% of people on treatment. So what other of the growth statistics or vital statistics can we look at? Well, there's several of them. The growth rate in 1995 was positive. More people were being born than were dying. In 2007, it's negative. The fertility rate was 3.2. The average woman was 3. The average woman of childbearing age gave birth to 3 children. That has come down to an average of 2.2. There were over 1 million births each year, and now it's less than that, almost 750,000. Infant mortality rate has increased. Under 5 mortality rate has increased. Death rate per 1,000 has increased, over double. And the number of deaths, you can see, is almost tripled. So these are huge numbers. Let's try to put it into perspective. In 2006, there were 1,400 new infections every single day. Every single day, another 1,400 infections a year. 950 deaths. That's 1 death every 90 seconds. As I've been giving this lecture, think of how many people have died. 71% of all deaths of people between the age of 15 and 49 were due to HIV. A 15-year-old in 2006 had a 56% chance of dying before their 60th birthday. Think of that. Many of you have children. Many of you have children who are teenagers. If you make it to age 15, most people will think you should make it to about age 60, right? You've gotten through all the childhood illnesses. You're unlikely to have a lot of the chronic medical disorders that will kill you early, may kill you later. You should make it to your 60th birthday. But over half of them have done. You can see in 1990, it was less than a third, 29%. So HIV prevalence has not yet reached a peak. It's just about reaching a peak now, we think. About over 2 million South Africans are HIV positive but don't know their status. Most of them don't feel they're at risk. Most of them are men who say, "Oh, I'm not at risk. How am I going to get HIV? I'm not gay. I'm not homosexual. I don't do any drugs." Some people say, "I'm in a relationship with one partner. How could I get HIV?" Well, as you can see, if about 40% of people who are sexually active, females who are pregnant, about 40% of them are positive, well, then you have a very high chance of getting HIV, even if you only have one partner. So I'd like to do a little comparison about Swaziland, which is a country neighbor to the north, and KwaZulu Natal. They share a border. They're very similar in terms of economy. Agricultural economies are very similar. So I'd just like to do a quick comparison of the two. Swaziland, the country, and KwaZulu Natal as a province. Sort of if you thought of KwaZulu Natal as its own little country, if we broke away. So Swaziland is a small country, 1.2 million people in the entire country. The adult HIV prevalence rate is the highest in the world at 38.8%. People living with AIDS, 220,000. HIV deaths, 17,000. Now compare this as #1 in the world in terms of prevalence But look how much lower the number of people living with AIDS and their deaths are. Much, much lower. This is a graph, sorry, the units didn't show up, but the prevalence rate of HIV in Swaziland, and it peaked in about 2005. This is the population pyramids of Swaziland. Very similar. They actually had a little bit different shaped pyramid to begin with, but similar trends are occurring in 25 and 50 years. What has happened to Swaziland since the early 90s? You can see their gross domestic product has decreased. Also didn't show up as well, but this was their economic growth has been negative since the 90s. In terms of agriculture, their yield, and one is a very large agricultural economy, and this is the total yield in corn or maize since 1992, and it has become down, 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 and down. Now that's not because of drought. The weather has been very similar. It's mostly because who's there to plow the fields? Who's there to plant the seeds? Less and less people. More people are sick. More people are caring for their loved ones. So their economy is actually suffering. This is a graph showing the human capacity. So the number of people in the public and private sector who have been lost due to HIV and AIDS. So this is non-HIV related deaths, and these are HIV related deaths. So these are your teachers. These are your policemen. These are your caregivers, your nurses, your doctors, all being affected by HIV. So in KwaZulu-Natal, our population is over 10 million. It's the largest, has the most populous province in South Africa, but its area is the seventh. HIV antenatal clinic rate, its prevalence rate, as we've said, is hovering at about 40%, which is even higher than the population of Swaziland. So if KwaZulu-Natal was its own country, we'd be #1 in the world in terms of HIV prevalence. Some clinics report over 60% positive rates in KwaZulu-Natal. 60% of the people coming to the clinic are HIV positive. There's some unpublished pediatric data done in a rural clinic in KwaZulu-Natal. We have Drakensberg, where they just took all kids who were born and did PCRs on them. Over 50% of them were positive for 2 consecutive months. So KwaZulu-Natal, much like Swaziland, is an agricultural economy. We grow sugar, citrus, pineapple, bananas, timber. So what is the effect on the economy here in KwaZulu-Natal? There are less people to work in the fields. What's the effect on the economy? What are the effect on other services? Police, teachers, healthcare workers. They're also becoming infected with HIV. So in South Africa, there's over 100,000 public servants known to be HIV positive. In 2005, there was 12.7%, about 40,000 South African teachers who were HIV. There are several members of parliament who are known to be, and some of them very openly, HIV positive. Well, I said some of them, I should say one of them openly HIV positive. So treatment, how are we doing? In terms of treatment, the numbers of patients on antiretroviral therapy is increasing. It is increasing. But it's not increasing at the pace that we need. From 2006, now there is updated data on this, but I still will show you the 2006 data. The number of patients who are stage 4, but not yet on treatment, you can see much higher than those on treatment. Now, you know, everybody in stage 4 automatically qualifies for antiretroviral therapy. And again, the same is true in children. And children even qualify at an earlier stage than do the adults. So only about 30% of patients with clinical AIDS are on antiretroviral treatment. And that's with clinical AIDS. Some of them may have low CD4 counts, but not clinically meet stage 4 criteria. 28% of clinically qualifying adults, 48% of clinically qualifying children are on ARVs. Only 9.8% of HIV positive patients. Now, not everybody who's HIV positive qualifies for treatment, but that's still a staggeringly low number. So in 2007, South African government, as I said, these statistics have come and have been public, and I accessed them and I got them all from searching the web. They're from reliable sources. So they were out there, so the government knows about them, it's not a secret. So in 2007, they came up with the National Strategic Plan. How many people in here have heard of the National Strategic Plan, Mr. Chairman? Not one person is raising their hand. Yeah. That's why I included this slide. Because they did come up with the National Strategic Plan. It was a very nice document. It probably cost them a lot to write it, but nobody ever heard of it. Nothing really ever happened from it. It had some great ideas in it, but it's a difference between an implementation. They wanted to focus on prevention, to reduce the number of HIV infections by 50% by 2011. Well, we're a year away, and that's not even close to happening. They wanted to expand treatment, care, and support. So they wanted coverage of 80% of those infected and qualified. Well, right now we're at 30. And we're a year away from this. They wanted to improve research, monitoring, and surveillance, all very important ideas, but nothing ever happened to implement that. They wanted to focus on human rights and access to justice. All of these are very important, very great ideas, but nothing ever happened to implement the strategic plan. So is this all doom and gloom? Is this all terrible? There's nothing we can do. Let's all just give up and go. I don't think so. I think there's hope. And you say, how can you say that? These statistics are terrible. Everything looks terrible. How can you say that there's hope? Well, I can say that there's hope because we can look to one of our neighbors. We can look to Botswana. Botswana in 2002 was ranked #1 in terms of HIV. #1 in terms of HIV. But their government stepped up. And they said, I don't want this to happen to my country. The president at the time, Festus Mogae, said if we continue at this rate, our population will be extinct. Our entire country will become extinct. We will all die out. So he said, I'm going to do something about it. And what did he do? He became the first president, the first country in Africa to start an ARV program. Every citizen in Botswana, free of charge, starting in 2002, could get ARVs. Not only that, he got lots of NGOs to come into Botswana and help him come up with a plan. How do we do this? How do we train these people? How do we train the staff? How do we get staff in here that know how to do this? And they trained the entire country on how to do it. In Botswana, in the early 2000s, the antenatal clinic prevalence rate of HIV was very high, about 38%. The number of the transmission from mother to child before antiretroviral therapies was extremely high. 35 to 45% of pregnant women transmitted HIV infections to their children. Now there's an ARV program. Now there's an ARV program with a strong government backing, with a strong public support, and very strong medical support from the whole medical society. And now, their antenatal clinic prevalence rate is less than 4%. Less than 4%. Gone from about 40% to 4%. That's amazing. In Botswana right now, the number of pregnant women who seek PMTCT. So they go into an antenatal clinic pregnant, and they say, I want to test for HIV, and I want something to be done about it to prevent my child from getting it. 98%. 98% of women in Botswana access PMTCT services. South Africa, it's not a lot of great data on it, but it's less than 50%. Less than 50%. So is there hope? Yes, I think there is. Because with support, with training, I think it can be done. Because Botswana showed us it can be done. These are pictures from children in Botswana that are doing well, they're thriving, they're on ARVs, and they're doing very, very well. So I think there is hope. I think with enough training, with enough people knowing how to do it, enough people testing, enough people treating, there is hope for HIV. Thank you very much. Any questions?